His topic today will be on the older women and breast cancer, geriatric evaluation and tailored therapy challenges. Dr. Marwan, please.
Thank you, Yasser, for this very nice introduction, and I would like to begin by thanking Professor Hisham and all the organizers, presidents and co-organizers of this wonderful meeting. I'm very pleased to be here for the third year of the row. And for those who doesn't know, my wife is half Lebanese, half Egyptian, so I'm very pleased to come back again and again to Cairo. I have a difficult task to sensitize you on an increasing problem in our medical oncology practice, not only in breast cancer, but I will try to tackle the problem from the breast cancer issue, and this is what to do with our elderly patients. So I would like to present, first of all, a little bit of epidemiological data. I will stress on the need of performing a geriatric performance assessment and present the results that I have performed on our patients in my institution over the last 1 year. And I will give you a small hints and glance on the updated recent recommendations 2012 for the treatment of these patients. This is how we think that elderly people are, but this is definitively not how elderly people are in 2013. We see them on the movies, they are taking their retirement, they are wandering all over the world, they are on cruise, love cruises even, they are, spending money. This is how elderly people are nowadays in Western countries. So if we continue to think that this is how they are, I think that we will not be able to move around. In fact, more and more patients are elderly than 65 years old, and within the next 20 to 30 years, a lot of our patients will be even more than 85 years old. So the life expectancy of our patients is increasing. What are we going to do with it? Especially if we look into breast cancer, and we know that the incidence of getting breast cancer will increase with age. So we're gonna have more and more patients living longer and more patients diagnosed elderly than 65 or 70 years. What are we gonna do? In fact, nowadays and today, we have nearly 50% of our patients diagnosed with breast cancer elderly more than 65 years of age. What is so particular of the problem of age? The most particular thing on the problem of age is that our patients at diagnosis have a lot of comorbidities, and you can see in this cartoon the percentages of comorbidities like previous cancers, myocardial infarctions, DVT, stroke, dementia, rheumatoid arthritis, etc., etc. A lot of our patients have at least one or two comorbidities, but still having a very good performance status and still having a very nice expectation of living. So the problem is not so easy. In order to try to quantify the problem and to see how fit are our patients, and I have been hearing through multiple presentations that this category of patients have been not substantially introduced or represented in all clinical trials, nor in the HER2 trials, nor in the metastatic trials, nor in the adjuvant trials. We do not have enough of patients more than 65 or more than 70 years of age represented in the trials. Second, we need to know that in this category of patients, everything or nearly everything that we know on the epidemiology or the distribution or the characteristics of the tumors can be different. For example, HER2 new evaluation or expression is nearly 10% in this population compared to more than 20% in younger population. ER and PGR expression is more likely to be more positive in this population when compared to younger population. Small tumors, despite the fact that we know in younger patients, smaller tumors do not have axillary lymph node invasion. Paradoxically, in this category of patients, smaller tumors has high lymph node invasion. So I will not continue till the end, but definitively this category of patients have different particularity and different prognosis if we have enough data on them. So we need to do comprehensive geriatric assessment in order to see what kind of solutions or therapeutic options we can give to our patients. This is why comprehensive geriatric assessment has been introduced early as 1989, and it is a multidimensional interdisciplinary patient evaluation which leads to the identification of the personal patient's problems, trying to tackle these problems and to decide what kind of therapy we can offer the patient. It is a three-step process. It needs to target the appropriate patient, to assess the patient and give recommendation, and also to implement the recommendation. In fact, this comprehensive geriatric assessment is a multidisciplinary approach, including with the oncologist, a lot of other social workers, physical therapeutics, dietitian, nurse, and also geriatrician. I will go very rapidly, but just you need to know that we are not only evaluating the physical capacity of the physical capacity of the patient. We are also trying to evaluate the functional domain of the patient, the medical domain of the patient, and one of the most important part, the cognitive domain of the patient. Very rapidly, the functional domain, you see if the patient is able to do daily living activities, is he able to instrument the activities? I go very rapidly. You go some medical evaluation to see if he have a hearing impairment, visual impairment, as well as you calculate a comorbidity index. You go on the cognitive domain and you see how is his mental state and is he depressed or not. As you know, a lot of our elderly patients can be depressed. And at the end, you look at the physical capacities. Just to make a small comparison, what we use usually on our patient, younger patient, is only Karnofsky performance status or the equivalence. And this one only looks on the functional status of our patient. And it's not as effective in elderly as in patients, as in elderly as in adults. Because the geriatric evaluation usually is time consuming and takes nearly 45 minutes to be addressed for each patient, there is a more smaller evaluation test called physical performance test, which addresses a little bit all these aspects, but usually it can take not more than 5 minutes in the evaluation. And it also looks into some few parameters like writing a sentence, simulating eating, lift a book, put and remove a jacket, turn on 360 degrees, etc., etc. I will not go into the details. In my institution, I try to see if we can perform this physical performance test of 5 minutes, and if it can replace the more time-consuming geriatric evaluation test. And we did it over a period on 100 patients over a period of 1 year. The median age was 76. We had patients up to 89 years of age, and the inclusions criteria were that the patients should be more than 70 years of age, diagnosed with cancer, knowing Arabic, French, or English, and absence of significant cognitive impairment, and there were some exclusion criteria like several severe medical conditions and Karnofsky scale less than 60%. So these patients were deemed fit on our classical evaluation, but when we performed this evaluation, we saw, and this is the distribution of the tumors, as you see, we had 17% of breast cancer, so breast cancer was also representative in this cohort. We see, just to make the story short, that the patient aged more than 70 years may benefit from a pre-screening assessment by Karnofsky scale or by this physical performance test, but if we had an impairment in the test, look, the Karnofsky scale up to 80% or less, the test was not clear enough how fit our patients were. And we needed this geriatric oncology assessment before giving our patient or submitting our patient to the treatment. And the treatment could be either a standard treatment or a more adapted, tailored, adjusted treatment to the general condition of the patient. I will, in the 5 more minutes which I will stand at the podium, give you a small glance on the recommendation, which are only recommendation or consensus recommendation of the International Society of Geriatric Oncology along with the European Society of Breast Cancer Specialists, and these recommendations have been recently published in Lancet April 2012. So these are the most updated recommendations. As you see, patients should be screened for their geriatric conditions. If the patient have no geriatric syndrome and or minor comorbidities, and that is a Karnofsky scale more than 80% and a very high scoring on the geriatric oncology test, he should be offered optimal cancer treatment like younger patients, younger than 65. If the patient has 1 or 2 identified problem, specific assessment by a geriatric evaluation test should be performed in order to identify the 2 groups of patients, the one which can afford optimal cancer treatment or the patients who will have a reduced treatment. In fact, the general recommendations for older patients are made on physiological age, on the life expectancy, on the time of diagnosis, the potential risk versus the absolute benefits, the treatment tolerance or what we expect to be the treatment tolerance, definitively the patient preference. I know that in our part of the region, the patient, especially elderly patients, usually we discuss with the family members and not a lot with the patient himself. And there are a lot of potential treatments barriers concerning our patients. And the relative breast cancer survival is the preferred way to describe the outcome of older patients with breast cancers, and the assessment of comorbidity and function should predict the likelihood of dying from non-breast cancer causes and should usually influence our decisions. So the geriatric assessment should be done. What about screening mammography? Usually we used to say that screening mammography should continue up to 70 years, but there is more and more data saying that even up to 74 years of age, screening mammography has or can have an impact on the survival of our patients. So remember that we can extend the screening mammography to 74 years. What about the treatment of ductal carcinoma in situ? Also, breast conservative surgery and post-operative radiation therapy are offered to elderly patients as it is offered to younger patients. So you should try to offer your patients as the younger patients. What about surgery? Also, for fit patients more than 70 years of age, where geriatric assessment shows you that your patient have a high score, the patients more than 70 years should be offered the same surgery as younger patients. There have been studies that show that sentinel lymph node dissection procedure should be done the same in younger than in elderly patient, and the lymph node dissection of the axilla is also indicated for clinically positive or highly suspected nodes in elderly, the same as in younger patients. The omission of the sentinel lymph node can be a reasonable option in some older patients with very small tumors with by some very positive good prognosis feature on their immunohistochemistry profiling. Radiation therapy is also offered as an elderly. Just I want to add one single word on the hypofractionated radiation schedules, which can be an alternative to the whole classical breast radiation therapy, which is usually offered to younger patients. It can be more convenient to this elderly population, where the patient would come only once per week to the radiation oncology center and not every day for 5 consecutive days. But we lack definitive data on the issue. Primary endocrine therapy is also the same as younger, and aromatase inhibitors are the preferred drugs, but still the side effects of these drugs can be more prone on these elderly patients, so you must monitor very well the side effects. I will go very rapidly on that, just to say that also adjuvant chemotherapy can be given to our patients, including anthracyclines or CMF. Also, HER2 targeted therapy is also offered to these patients, as well as taxanes, and there are a lot of publications, scared publications or subcategory of patients through bigger publications, which shows that it is safe to use this drug in elderly patients as we use them in younger patients, as long as patients are being well assessed and they have high score in their geriatric oncology evaluation. Otherwise, you should taper, you should identify, and you should choose the drugs that you use. Patients with metastatic breast cancer also can be given HER2 targeted therapies and chemotherapies. Also, bevacizumab is active in elderly patients, as well as it is also still recognized in Europe and not in the United States, as you know. Just to end, that careful drug prescription is warranted because the physiological age-related pharmacokinetics alteration exists at this age because of the comorbidities, and especially because of the polypharmacy. And I highly stress the need to get the help of clinical pharmacists in your practice in order to look in all the drug interactions that can exist between the classical drugs that your patient is taking and the hormonal therapy and or chemotherapy that you are offering to them. Drug compliance is also a problem in this category of patients and should be very actively promoted, and very close adverse event monitoring should be offered to these patients, as well as a proactive management of the side effects, preventing the appearance of the side effect. You should also discuss the patient expectations before deciding your therapy, and also you should look to the barriers of the treatment. For example, if there is a long way to go and to bring your elderly patient from home to the oncology center, sometimes there is a barrier into bringing these patients to the oncology centers. And please be aware of the physician's bias. We have our bias. We tend to want to decide what is the best for our patients. And I think that it is time to go to recommendations and to hear what our patients want us to do for them, and not be convinced on personal basis this patient needs a treatment or this patient doesn't need a treatment. We should think very scientifically and stick to the recommendations. Male breast cancer is offered the same therapy as for women breast cancer. So as in conclusion, no aspect of management of elder individuals with breast cancer should be driven by chronological age alone. Multidisciplinary oncologic and geriatric approach can optimize this management and is optimizing it. Patient preference, comorbidities, and potential toxicities should always guide us in the management decisions. Patients should be closely monitored with prompt intervention for toxicity, and several breast cancer trials in elder individuals have closed prematurely because of poor accrual. In some settings, prospective subgroup analysis and observational studies could be practical alternative sources of information to guide our management, and everybody is encouraged to put elderly patients in clinical trials. I would end by encouraging everybody to submit your clinical research in the region to our region Pan-Arab Journal of Oncology, which is the official journal of the Arab Medical Association Against Cancer, and would highly recommend to you at least to go and visit the site of the International Society of Geriatric Oncology, where you can see all these recommendations and other helping you in dealing and treating your elderly patients. Thank you very much for your attention.
Thank you, Marwan, for your excellent presentation, and usually there is no question because of the shortage of time. Thank you, Professor
Thank you
Marwan.
very much.
Now we'll leave